sir. I'll be talking on one of the very old, long investigative modalities which has been there for many decades, but has still now not picked up really in a way, kind of more mundane as compared to the other prolific investigations which have been talked about before by my previous speakers. The evolution of the ultrasound, dates back all the way till World War II, when it was first invented from the B-29 turret parts. The application in optical pathologies was done by Munt and Hughes in 1956. Osoinik was the main person who standardized A-scan and has laid the foundation based on which we even today follow the description of ultrasound for the eye. And in 1990 onwards, it was the 50 megahertz UBM probes which were developed. The initiation of the signal starts with the use of piezoelectric materials, which most commonly which are used are lead zirconate titanate, barium titanate, and lead titanate, and it works on what is known as the pulse ecosystem. It's actually kind of locates a particular lesion inside the eye based on the time delay between the transmission and reception. It is something like the Michelson interferometer, but instead of light, it uses ultrasonic sound waves. This is the basic layout of the machine, how it does. It's the pulsar which contains the piezoelectric material, and from the probe it sends in the sound waves. It receives from the same probe, the receiver displays the and finally it is displayed on the unit. The ultrasound speed zones for the eye, the cornea and the anterior chamber, the speed of the sound is 1532 meters per second. The lens has around 1641 and the vitreous is 1532. The devices actually measure time and not the distance directly, so it's the time delay which is measured. The patient positioning, probe placement and the measurement is very simple. It is either supine or a patient lying down flat with the eyes closed or open. And although the textbooks do describe it as to be taken on even open eyes, but most of the practical purposes everybody uses is a closed eye situation. The probe is placed on the top of the eye, and particular angles are there on which we can place the probes and we can acquire the scans. The examination technique includes, there are 3 steps for it. The basic scanning includes the normal 8 meridians, which I'll be just coming to shortly. Then once the lesion is identified, we go to the topographic, quantitative and the kinetic criteria for differentiation. And finally, combining all these data, we come to the final ultrasonic diagnosis. So the transocular scanning and paraocular scanning, these are two areas which has to be looked, that is intraocularly and even in the orbit. I'll be more pertaining to mainly to the intraocular scans. The examination techniques include the contact method, in which the probe is placed directly over the globe, and the immersion technique, in which we have a water bath, or we have something what is known as the Prager shell. These are the 3 probe orientations which are historically defined: the transverse, the longitudinal and the axial scans. This is the transverse cross section, very simple to identify. When you have the probe in your hand, there is a marker on the edge of the ultrasound probe, which if lies parallel to the limbus is the transverse scan. That is how it is going to scan the entire area, and we have to scan all the way from the posterior all the way till anteriorly. We can move it from the limbus to the fornix, and we can scan the area in the contralateral quadrant. This is the longitudinal section, in which we orient the marker on the probe perpendicular to the limbus, and this is the axial scan, in which the probe is placed directly on the cornea. Usually this is only used to look at the posterior pole and is avoided due to lens distortion. After which the criteria for topographic, quantitative and kinetic data are taken up. Topographic looks at the location, shape, size and borders. Quantitative at the internal structure, reflectivity and absorption, and kinetic looks at vascularization, mobility and consistency. Now there are 2 parts to the ultrasound. It is called a B by A scan or an A by B scan. depending upon which scan part is more prominently displayed on the unit or the printout. The A scan is the amplitude scan and B scan is the brightness scan. So A scan gives you a quantitative analysis and the B scan gives you a topographic information. And the indications for ultrasound are very simple. It's opaque media. Even in clear media, in some cases like ciliary body lesions, tumors, choroidal detachments and retinal abnormalities and foreign bodies. What and how to define? First, we look at the lesion. Now, the lesion which has typically been defined, it can be either a point lesion, it can be a membranous lesion, or it can be a mass lesion. It can the echogenicity has to be decided based on comparison with the scleral echogenicity. It is low, moderate, or high. Anything which is almost as high as the sclera is a high moderate, high intensity, high echogenicity. And something less than 40% of the scleral intensity is called low echogenic. Anything in between is moderate. Then we look at the location, the dynamic or the after mobility, and the appearance after reduction of the gain. These are the main points which are looked at. After coming to the theoretical part of it, I will just take you through a few clinical examples in which we will just skim through a few important cases. Now, there is no specific order in which I will be talking about them. This we can see is a dome-shaped lesion which is seen in the posterior part of the globe, and it shows a hypoechogenic area underneath the lesion. This typically is seen in a serous choroidal detachment, which is seen in many cases of hypotony or trauma. Another case which has a similar pattern, and if you see, rather than looking at a static printout, if you look at the dynamic scan, it gives you more data as compared to what we can see on the printout. Here we can see multiple mound-like lesions which are seen in the posterior part. Along with it, if you look at towards the end of the scan, we can actually see there's a hyperreflective membrane which comes in this area, and this gives rise to, we can find out that there is a retinal detachment along with the choroidal detachment. This photograph I have taken up from the internet, but this is actually a very nice depiction of what you can actually pick up with an ultrasound. This is a case of a localized retinal detachment, which actually we can locate the operculum, and with the after mobility, we can actually see how the thing behaves. This is one of my cases which I operated recently. In this, actually, this has two important points highlighted very categorically in the same frame together. If you look at it, there are two membranous lesions. One is a hyperechogenic, the other one is moderately echogenic. One has one on the top is actually a retinal detachment which has a flickering movement with the after scan, whereas the posterior vitreous detachment has a good after movement. This is another case in which we have a membranous echo in the temporal section as well as the superior section. This membranous echo goes and attaches all the way onto the optic nerve head, and if you look at the thickness of the membrane here, the membrane is quite thick, and we can see some cystic changes along the anterior part of the membrane. And there are hyperechogenic, moderately hyperechogenic membranes which are seen in the inner part of the lesion. This is PVR with a long-standing retinal detachment, which is seen in a long-standing retinal detachment case. This is another case which actually had undergone silicone oil removal elsewhere, and following this, the patient developed some trauma and had pain in the eye, for which she was examined again. And due to absence of view of beyond the anterior segment due to bleeding, we could see closed funnel retinal detachment and hemorrhagic choroidal hemorrhage surrounding the retinal detachment. Another common occurrence which is usually seen in the clinical practice is a condition called asteroid hylosis. In this condition, we see multiple hyperechoic lesions which are seen in the mid to posterior vitreous cavity, maybe all the way to the anterior cavity. The striking point is we can see an empty area of clarity between the retina and the posterior limit of the lesion, which is known as the limbal interval of the interval of Vogt, and this is characteristic of asteroid hylosis. A similar pattern which is seen, which may be mistaken occasionally by novices and initial adopters for the ultrasound B scan is this condition in which we can see a freely moving membranous lesion underlying which we can see multiple moderate to high echogenic points which are moving along with the eye movement. This is what is typically known as the washing machine sign, and it is seen in subhyaloid hemorrhage, which is commonly seen in diabetic retinopathy. Another case which we can see, another clinical condition which we can see commonly in diabetic retinopathy is this clinical scenario where we can see multiple hyperreflective membranes spanning across the posterior edge of the globe. This here, when you see, is a hyperreflective membrane, and based on actually, if we are able to titrate the gain, we are able to differentiate whether it is the retina or it is the hyaloid or it is the blood-laden PVD. This membrane here is the hyaloid. This is the subhyaloid hemorrhage. This is the focal traction, and this element here is the subretinal hemorrhage. If we come to the clinical picture of the same case, you are able to delineate it very clearly. Another condition which is commonly seen in post-operative cases is silicone oil filled eye, in which it is very difficult to appreciate the posterior limit of the globe due to the slow speed of the ultrasound in the silicone oil, that is around 972 meters per second. I'm sorry. This is a case of posterior scleritis which shows a D sign in the posterior segment. Another case of endophthalmitis which can be seen, in which we can see multiple point echoes in the posterior segment, and they are freely mobile with the dynamic scan, and this can be early or advanced, and we can pick up very early and we can initiate treatment early on. This is a case of trauma in which we can see a posteriorly dislocated crystalline lens along with dispersed clinical cortical material. This is a case of retained intraocular foreign body. Here what we see is not the optic nerve shadow, it's the after shadowing which is seen with a metallic intraocular foreign body. This, just for completion's sake, this is actually ocular choroidal melanoma, which is seen clinically like this, and these are the characteristic features which are seen in case of choroidal melanoma. This is another case which is a chronic retinal detachment along with an osteoma which is seen in the B scan. Another case of disfigured globe in which anteroposteriorly foreshortened globe is seen with total disfiguring of the details of the intraocular contents. This is a very beautiful depiction of giant retinal tear on ultrasound, in which we can actually see the rolling edge of the GRT which is seen on the B scan. And this is a case of TRD. So when we are, I'll just skip to the last, when we are reporting an ultrasound, this is how we should be reporting the eye, the details, and deciding which lesion is there, their size, shape and characteristic based on all the patterns which have been described earlier, and final presumptive diagnosis has to be given for the clinician to make a diagnosis based on the findings. Thank you.
Thank you, Jyoti, for that talk and the final slide of how to report an